We're just gonna, I have about, let's see, 15 or 20 questions.
Okay.
Just about the clinical applications, the procedures, all that kind of thing. If we could just first have you say your name and your position and maybe just a short, brief overview of your primary responsibilities.
Sure. Yes, my name is Dr. Brian Smith. I'm a neurologist at Achieve TMS East, and I am the Chief Medical Officer, so I'm in charge of medical procedures and medical supervision of the practice.
And can you tell us what TMS is?
So TMS is transcranial magnetic stimulation, and it's the latest FDA-approved non-invasive treatment of major depressive disorder and with what we refer to as deep TMS for obsessive compulsive disorder. So what we're doing, we're using high-powered magnets similar to that of an MRI to send magnetic impulses into the brain and stimulate parts of the brain that are associated with decreased activity and result in depression. So when we stimulate the brain, it results in release of neurotransmitters and activates those areas and those circuits that actually are producing depression. And when we do that, we can actually result in major alleviation of symptoms of depression and now obsessive compulsive disorder.
And what does the procedure itself involve? How is that done?
So basically, as you can see from the device back here, a person comes in and they sit down in the chair, and this helmet is placed on the head, and then they receive a series of pulses, of these magnetic pulses, and it feels like a little tapping on the head. And during about 30 minutes, they'll receive over 1,900 pulses. And after the procedure is done, they basically can go back to whatever they're doing. They can drive into the office and drive home afterwards. It's a little bit uncomfortable when they feel those pulsations, but people usually get used to it. They usually watch a video while they're sitting going through the treatment, and that's usually the entire process.
And people may be more familiar with something like ECT.
Mm-hmm.
Is this related, similar, different completely?
It's very different from ECT. So ECT, electrical convulsive therapy, is a treatment that's been around since the 1930s. And that's very different. That's a very invasive procedure in that people receiving ECT, it has to be done in a hospital setting. They receive general anesthesia, so they're actually anesthetized during the procedure. And then they're given an electrical, not a magnetic, but an electrical stimulation, a powerful electrical stimulation that produces a seizure. And that seizure results in that a series of these treatments, usually about 12 or 15 of them, will result in alleviation of depression. ECT it has a lot more side effects. Again, it's a much more invasive procedure, and it also has significant side effects, including potential loss of memory. With TMS, we do a series of 36 treatments. So patients will come in 5 days a week, usually for those about 7 weeks, and they'll receive these 30-minute treatments 5 days a week, and that's the entire course that we initially do for patients with depression.
And how long is that effective for?
That's a great question. So for some, it varies. So the interesting thing about TMS is, unlike medication, where if you said, okay, I'm going to give you 35 days of medication and then I'm going to stop it, you'd expect after that point, even though it was effective, that the person's depression would then come back. TMS has a very interesting effect. You know, we talk a lot about brain plasticity, about the brain's function and ability to adapt to changes. What we're doing with TMS is we're affecting brain plasticity. So we basically stimulate these circuits that have not been activated, because a lot of what we're looking at now, when we look at whether it be neurologic or psychiatric disorders, we look at the release of chemicals in the brain called neurotransmitters that are not as active as they should be. So for example, with depression, one of the common things everybody sees is these SSRIs, these serotonin specific reuptake inhibitors, and we increase serotonin in brain. And these neurotransmitters work very well, but we're releasing those neurotransmitters, but we're also stimulating specific circuits that are involved in disorders like depression and obsessive compulsive disorder, and resulting in significant improvement as a result. But it's affecting, and as far as your question goes, when we do that, we can have long-term effects because those circuits sometimes are reestablished. And so patients sometimes may be it may change them indefinitely. There's been studies following people out for about a year after they stop treatment, and about 62% of patients that respond are continuing to respond. Some patients will require booster treatments, but it's all really individual. We never know. We have had patients that we treated and it's several years later and they're still doing quite well. So it's individual, but the impressive part is that we have long-lasting changes in the brain as a result of this treatment.
Can you tell me, how is this applied? Is it prescribed by your primary care doctor?
Mm-hmm.
Are you free to choose it? Or how is it applied?
So people are referred. So, and some people are also self-referred. But usually what happens is you talk to your primary care doc, your psychologist, your psychiatrist, and they will refer you for treatment. Patients have to have failed medications. So the impressive part about transcranial magnetic stimulation is that all the patients we treat have failed multiple medication trials, usually 3 to 4 medication trials, and also have failed psychotherapy. So this, after being through all these treatments and nothing works, then they're referred usually for transcranial magnetic stimulation. And so they can be referred by any of these folks. And then what happens is, with our practice, for example, we invite people to come in for just a free information session. So they'll meet with one of the technicians, they'll see the equipment, they'll have questions answered, and then if they want to go forward at that time, then we would have them meet with one of our psychiatrists who will assess them to make sure that their diagnosis is appropriate. So currently, for depression, patients have to have a diagnosis of major depressive disorder, and also we make sure they don't have any reasons for not treating them. So this is a magnet, so similar to an MRI, people cannot have metal in their head or any kind of metal, from about the neck up that could be stimulated or heated. So we basically evaluate patients to make sure they don't have that or any history of other contraindications for the treatment.
And is this used in conjunction with a medication they might be taking, or is it replacing a medication?
Great question. So we always have patients, some patients will, most patients will continue whatever treatment they're doing because we don't like to do 2 things at once. So some patients may find that, people will say, well, why am I going for transcranial magnetic stimulation if they're already on an antidepressant? Well, sometimes the medication works, but partially. We'll have a patient, for example, that says, since I went on my antidepressant medications, I'm not suicidal every day, all day anymore, but I'm still so depressed I have a hard time going out the door. So sometimes the medication's working, but it's not working enough for them. So most patients, whatever they're on, we keep them on those medications. Whether they come off those later as a result of treatment, that's usually decided later on.
Train's going live.
Yeah, it's good effect. Yeah. Where should I be looking at, you or at the?
You can look at me.
Okay.
You don't have to look directly into the camera.
Okay.
It's fine. Look at my eyes is fine. Okay, so the train's gone by. So I have. Can you go into more detail about how the magnetic pulses specifically interact with a person's brain? Sure.
So basically, when you're basically allowing these magnetic pulses, and one of the important parts of that is that when you give, for example, electroconvulsive therapy, they have to give really high electrical stimulation because there's resistance to electrical stimulation. It doesn't like to go through the scalp. It doesn't like to go through the skull, so there's a lot of resistance. With magnetic pulses, they go right through the skull to the brain, and once they get there, it's based on what's called Faraday's principles, electromagnetic conductance. And what happens at that point in time is those magnetic impulses change and actually cause an electrical stimulation in the brain. And when they cause that electrical stimulation in the brain, they cause the release of neurotransmitters. And again, when you're stimulating, for example, with depression, we target the left frontal cortex, left frontal part of the brain. And when you do that, you're not just stimulating the left front of the brain, but what happens is it affects that circuit. So if you look at imaging studies of what happens when you stimulate the front of the brain, you'll see that the stimulation is going all the way down to deep brain structures and sometimes crossing over to the other side, to the right side of the brain.
Why is depression such a significant side effect of chronic pain?
So there's a relationship with it too. So it's very interesting, the relationship between pain and depression. So patients who are depressed, who have pain, certainly depression will worsen. Depression will worsen most symptoms we have. So depression will worsen pain, and similarly people who have pain frequently will be depressed. It's almost a similar relationship to what we see with sleep and in depression. Most patients, every Most patients who are depressed have sleep issues, and if you take people and you sleep deprive them, they will get depressed. So there's a strong relationship between the two.
Do you have other patients besides Kimberly who have depression that stems from chronic pain?
Sure. Yeah. No, there's a fair amount of patients, especially patients with chronic pain. Is not much more depressing kind of symptom you can have, because it basically, as we know, most of us have had a day where you have back pain, or a day where a few days where you've had some kind of pain, and it really does limit all of your activities. And when you start limiting people's activities and what they can do and how they can function, it's a natural reaction to get depressed.
And this has been effective on the type of depression that is associated with chronic pain? Obviously it's effective on many kinds of depression in general, but the type of depression associated with chronic pain, what are the...
That hasn't been clearly studied. So whether you're saying if you have someone who has no history of depression and then they get chronic pain, they're depressed as a result of that. Basically what we do when we assess people for this is they have to meet criteria for major depressive disorder. So if their pain results in them having major depressive disorder, and which is the length of treatment, length of the symptoms and daily symptoms, then usually they will also respond.
So patients are evaluated on a case-by-case?
Case-by-case. We want to make sure that we're treating the right people, that they're getting the right treatment, that they've tried the right treatments first. Again, it's mostly an insurance issue, but patients have to have tried and failed medications first. Yeah.
Is Kimberly specifically unique in any way? Or is she just...
As far as her response?
Yes, as far as...
So what I was just speaking to with her, it sounds like she's had a great response in regards to her physical symptoms. She's just saying her migraines have responded. We also want to be very careful when we present this treatment that we don't say it's a panacea for everybody. So if you look at the data on TMS, and the thing I'm impressed with when I first got involved with this, because I do come from a slightly different stance as a neurologist, if you see patients who are refractory to other treatments, whatever type of disorder you have, so when you have patients that don't respond to anything else, and then they come in and they respond to TMS, the response rates we see are about a 60% basically improvement rates, and by that what we mean is about a 50% decrease in depression. And then we have remission rates of about 40%. And those are kind of crazy numbers, because most people, if they've tried everything else, don't respond to the next treatment, but they respond to TMS. And so we also will see sometimes all those other symptoms, like she said, right away her sleep improved. And that's very common. Part of that is that there's that strong relationship between depression and sleep. So what we say to patients a lot of times, it's very common, is that the first thing that patients will note is when they start the treatment is that their sleep improves. So I look at this treatment, I say, okay, I have patients who are depressed, and we're asking them to come in for all these treatments, 36 treatments. We're asking them to come in for this whole series. What's the likelihood that someone who's depressed is going to come in every day? Most people, even if you had a healthy person, they have to come in for a physical therapy or even something they like to do. If you said, I want you to come in and meet me to do something, watch a movie every day, that's like, I can't do that every day. What keeps people coming in and finishing these treatments? So when I first was learning about TMS, I was out in California at one of our sister practice out there. I talk to patients, and it's the fact that they do see improvement. So it's like Kimberly describes, her sleep improved first, and then all of a sudden you feel like your thinking is clearer, you're not thinking is so foggy. And then that whole sense of depression may be more towards the end of treatment, or sometimes even after they finish treatment. And then the other thing that's always interesting is we see that sometimes patients will say, I think I'm a little bit better, and we'll have a family member in the room, and the family member's like, what do you mean a little bit better? We went out to a movie Tuesday night, and Thursday night we went out for dinner. We haven't done that in 14 years. So we see patients who have had long-standing depressions that improve and change.
How widespread how widely used is this in this country?
Well, it really has only been since 2008 it got FDA approved. So it's spreading right now, but there's still states where there's only maybe 1 or 2 treatment centers in the entire state, and then you have other areas. But it's very interesting in medicine. I always quote a study. It was done in Journal of American Medical Association, and they talked about dissemination of medical information. So when you have a new treatment or a new that comes out, how long does it take before medical society and medicine in general picks it up? And on average, it's about 14 years. So we're kind of, people laugh when I say that. I say, but look at TMS. It's been 11 years, and I'll run into psychiatrists, and they're not really that familiar with TMS. So it takes a long time for it to get integrated. But this type of thing, talking about educating patients, because the important thing here is depression and suicide. We hear all these stars and famous people committing suicide. I actually had a friend not just about 4 months ago committed suicide. There's still a lot of people out there who are severely depressed, that don't reach out, that don't have treatment, and this is something that can be offered to them. Yeah.
Can you tell us a little bit about the origins of this treatment, how it was developed?
Yeah, it was actually developed in 1985 by a guy named Anthony Barker in England, and it started out by basically, he's actually a friend. We do talks together, and he tells great stories about his experiences about how they're in London. And they were using this new they knew you could stimulate the brain electrically, but they didn't know that you could use magnetic impulses. So you start with an electric current. The electric current goes into a coil. That coil then generates magnetic impulses that can go into the brain and then cause electrical discharges. So it's this Faraday's principles. And so they were actually in his laboratory that day, and all of a sudden they stimulated the patient, and they saw the arm move. And this has never been done before. And he said the word got out all over London. And he said by the end of the day, they had hundreds of people coming into their, as he would say, laboratory, and coming in to see this dramatic thing that all of a sudden you could use magnetic impulses to stimulate the brain. And so it started there, and then in the 1990s, there's been studies on depression that have been reported since 1996. Big good studies like in Lancet and such. So it's been around for a long time, but it didn't really get publicized. It didn't get FDA approved until 2008. So that's why it hasn't been out there yet.
How large is this practice? About how many patients do you treat?
So we have 15 sites in Massachusetts, and we're just opening our second site in Connecticut. And we usually average about 8 to 10 patients per day at each site. So quite a few patients.
And you said that the patient does feel something. Is it what?
It's uncomfortable. It's a tapping. It feels like a tapping. So initially it's a little, sometimes patients are a little taken aback by it. But usually after they get used to it, it doesn't bother them. And again, usually we have TV, they watch TV during their treatment for their half hour. They pick a TV show. And it's really not that uncomfortable.
So they come in, it's about a half hour under the
helmet, with the helmet on, yep.
And how often do they come? What is the course of treatment?
So 5 days a week for about 7 weeks. Yeah.
And that can last either years or...
Well, hopefully it works. Some people don't respond to treatment. I always want to make sure I say that. I don't want to make it sound like we think we're going to cure everybody, but there's some people don't respond. If people do respond, then they tend to have a more long-lasting response, after it. And it can be, it's really one of the things that we're working out now. Because this is a new treatment, the insurers right now will say to us, you have this 36 treatments you can use. And now we're saying, but what happens if patients have relapses? People with, and it's like saying to someone, we're going to give you this medication for your blood pressure. We're going to give it to you for 3 months. It's like, well, what happens when their blood pressure goes back up again? Well, the nice thing about TMS, as I mentioned, because it affects brain plasticity, we can have these long-term changes. But not everybody does, and everybody's different. Somebody might last a short time, some a long time. Some people with severe depressions, they might have a relapse that occurs. So that's where a lot of studies are being done now about what's the best way to approach that. But it's so individual, it's hard to come up with a clear guideline, a clear protocol to say, okay, if someone, if they start to feel a little depressed, do you get them right back in? Do you watch them? Do you have them work with their psychiatrists on other issues? Or, what do you do with those folks? And that's what we're working out now, the details of trying to.
And is it, how many insurance plans cover this?
Pretty much all insurers, including Medicaid and Medicare. So almost basically all the insurers cover it. Yeah, which says a lot, because especially some of the the government insurances, usually they're not going to pay for anything unless they think there's a lot of information. And if you Googled, or you went on the big medical search line, is called PubMed, it's free, and if you typed in transcranial magnetic stimulation, you'd get over 15,000 articles. And because it's such a safe procedure, the nice part about it, transcranial magnetic stimulation, it causes a little neck pain usually, because probably holding their neck, or a little headache. But outside of that, it's generally very safe. There's one more serious side effect, which is seizures, which are rare. If a person does have a seizure, it happens when they're being treated only. It doesn't cause them to have ongoing seizures or repeated seizures, but that does occur in about 1 out of every 1,000 patients treated.
You mentioned that patients tend to want to come back because they feel effects.
Yeah.
How quickly, after how many treatments does a patient start to feel effects?
Yeah, that's the variable thing. So sleep, again, as I mentioned, that kind of typical, potentially typical thing, as even you mentioned earlier, that usually sleep improves after the first few treatments, clearing of their cognitive clearing. They feel fogginess starts to clear, mood starts to improve. But that's also variable. It can be during the first week or two. Sometimes patients it's later, and even it can happen after treatment's over.
You mentioned that a rare side effect was seizures.
Yeah.
Is there any other side effects?
Basically, the headache and neck pain are the two most common side effects. Yeah.
But this treatment is
no cognitive. It doesn't affect cognitive impairment. Doesn't affect your memory. Doesn't cause any changes. The other changes as far as cognitive function.
So this treatment would be probably highly medically appealing because it's so effective with so few side effects.
And that's why if you look up if you pick any psychiatric disease, any neurologic disorder, and you type in TMS and you type in Parkinson's, you'll get hundreds of articles. You type in Alzheimer's, you'll get hundreds of articles. You type in basically PTSD, you'll get articles. And so there's research being done in all those areas. There's the Brainsway is currently doing addiction studies, which is important. So everything is being looked at because exactly that. It's a very safe, almost no side effects, and has potential to really have great results.
So it has a lot of different applications.
Potential applications. So I say that because currently the only FDA-approved treatments for TMS are for a major depressive disorder, and then there's two types of TMS. There's a standard, and then there's a deep. Ours is called deep TMS. It uses a different type of coil that generates the pulses, and it does a deeper pulsation.
Could you describe the deep? Start again with
Yeah.
the deep.
So there's two types of TMS. There's a standard, which uses what's called a figure 8 coil, and that usually has like a banded device that is held onto the head. And then there's deep TMS, which we are doing. The difference between the two is with deep, the coil is a very complicated, very complex coil, in that we have a broader and a deeper penetration into the brain. And so so with deep TMS, the FDA a year ago August, approved treatment of obsessive compulsive disorder. But as far as other indications, there is a simpler device called single TMS that's used for migraine. It's just a handheld device that goes on the back of the neck that has been FDA approved.
And what's particularly unique about this practice?
I think the fact that we're using the deep TMS, I always say it's just basically a much more sophisticated device that not many people use because it's a much more expensive device. So a lot of practices have the standard TMS. Ours is deep TMS. The other thing I think our attention to patient care. I mean, everybody says that, but we really try to go out of our way to make sure that patients are screened appropriately, that our staff is that we have great staff, that we have good relationships with patients, and also that we communicate with their other treating providers. So we don't view we basically do the TMS component, but we really value the other parts. So for example, patients should have a therapist involved. They should have a psychiatrist involved. They should have all these people, and we should be part of a team that's treating them. And part of that is making sure we communicate really well with them. So we try to we do scales, for example, depression scales, and we send out, let their treating people know how are they doing, what's happening with this. And the other thing that's really interesting and important part about that too is patients improve. Now, improving sounds like a great thing, but if you've been depressed for 20 years and all of a sudden you start improving, you have no idea how to deal with that. So all of a sudden you're different, you've changed, people start expecting to be different. That's really, really tough. So we really need therapists to be involved. I mean, I remember talking to a patient, she said, you know, I was an artist for years, I haven't done art for like 10 or 15 years, people see him better, they're like, hey, you gotta go start doing art. She's like, I don't know if I can do that. And all of a sudden she's now stressed out because, you know, there's these expectations and changes that have happened with her. So even improvement can be stressful for patients.
What's the size of the staff here?
So at each site we have, well, within the whole practice or just each site?
Each particular practice.
So at each site we always have a psychiatrist, and then we have technicians involved. So there's a psychiatrist that will do a psychiatric evaluation of every patient to make sure they're appropriate for treatment, and they'll also do the initial mapping, where you basically decide where the helmet should be placed to give the best treatment to the patient. And then we have technicians that are trained, that we train and also train through the company that does that owns the equipment to make sure that we're doing everything appropriately.
So technicians are trained by the company?
By us and by the company, yeah. We have a lead technician that will train them, and then there's I should say they're certified by the company, that they have learned. We train them, and then they're certified by the company.
And the technicians aren't medical, do they have a medical background?
Not usually. No, usually they have an undergraduate degree in a psychology or biology type of background. But we train them basically and educate them in about TMS.
So what is the composition of the medical personnel here?
Well, I'm the one neurologist, and then we have a group of psychiatrists. We have, I think, probably about 10 different psychiatrists that work for us on various levels in the practice.
And Kimberly is really interested in advocating for this treatment. What's the best way to get the word out about it? What's the best way to advocate for this treatment responsibly? Yeah,
I mean, I think that's a great point, responsibly, because I think what you're doing with this type of thing is, one is I think we want to present information. We want to also present it in a way that's factual. You know, again, like I said earlier, we're not going to make everybody in the world better. You know, when sometimes I give a talk and I'm so excited about this because we're offering hope to people, and people say, "Oh, are you saying that you're going to that you're going to fix everybody?" It's like, no. But there's a large percentage of patients that we can get better, and we can, you know, people who are depressed, that we can improve and minimize things like suicide and such, and improve quality of life. So I think just these educational things, being out there in the community, talking to people, having them stop by. You know, we do educational sessions, or we do evenings where people can just come by and talk to staff here and see what it's like and see if they're appropriate for the treatment. But it's a great thing to offer to people out there who are suffering.
Besides just a follow-up, besides a referral from a self-referral or from a primary care or psychiatrist, does this require a prescription of any kind? Or?
Well, basically it's done by the psychiatrist that sees them. It's not a technical prescription, but they do write an order of how the treatment will be given.
The psychiatrist who sees them here, or their psychiatrist?
Here, yeah.
And how, if somebody wanted to seek out treatment here, could they just, on their own initiative, ask to see one of your psychiatrists and come in to be evaluated? So usually
we'd usually have them come and meet with one of the technicians first, just to see if everything's appropriate and such. You know, like, does it make sense for you to move on? Because some people might come in, they'll say, I want this, but I've never been on antidepressant medication. It's, you know, the insurance is not going to cover it. Or they come in and they're, you know, for whatever reason, they've never been seen, and they don't even have a psychiatrist, or they don't have a diagnosis, or they have a different diagnosis. So usually we have someone just come in to see if it makes sense, and then if it's appropriate at that point, do it. Then we'd have them see the psychiatrist.
Is there anything else you want to put out there about this treatment, about the treatment in general, the culture of the treatment, the history of the treatment, anything that the most important piece of information you'd like to get out there about this?
No, I guess the main thing would be that, you know, for anybody who's suffers from major depression, and they've tried medications and they either have not worked or not worked effectively enough for them, they continue to have symptoms, then to consider this treatment. And, you know, the expectations are that, you know, about that response rate, about 60-70% of patients will respond to this, meaning their depression would be decreased in half depending on depression scales, and about 40% can go into remission. So it's something to seriously consider. If they have major depressive disorder, and now patients with obsessive compulsive disorder, we're now also treating those folks, which can be a very difficult to treat disorder. Patients with obsessive compulsive disorder are still getting brain surgeries done, where they go in, because I talked about a circuit, but the circuit in obsessive compulsive disorder and OCD can be so difficult to interrupt that they actually go into the brain. They used to do it actually by going through the brain, but now with gamma knife and putting holes in parts of the brain that are part of that circuit. So you have about 40% of patients that are very impaired by OCD. And so the fact that we can offer them something when medications fail again, instead of going for these more invasive procedures. So with depression, before going for something like ECT, you have something like transcranial magnetic stimulation that can be potentially very effective. And then instead, before going for something like a brain procedure, if medications don't work, you can have something like transcranial magnetic stimulation and hopefully have a response. But the other thing we're hoping, this is just the beginning, we're looking at all types of disorders to treat. And one of them is pain. And pain there's a lot of studies on pain and transcranial magnetic stimulation that are out there. There's studies on migraine. But the issue is that we don't have enough controlled studies to go before the FDA and say, here's what happens. It's a very interesting thing with transcranial magnetic stimulation, because you'll have a study done, and some people, people will do different things. Some people will target one side of the brain, some might target a different part of the brain. Some will use a very fast stimulation, some will do a slow stimulation, some will treat 5 times, some will treat 20 times. So you can't really take all that information and consolidate it and say, here's what you need to do. You have all these scattered, so you need people to do the same thing and see what works well, and that's what will end up being effective. The other thing I'll just say is that about transcranial magnetic stimulation, it says stimulation, but the other thing that can happen is that when you do TMS, if you do a fast stimulation, more than about 10 times per second when we do it, and it's a very fast kind of stimulation, it tends to be excitatory. It tends to cause stimulation of brain cells and neurotransmitters. If you do a slow stimulation, 1 time per second, you can actually inhibit brain function. So it's fascinating. So if you think of something like seizures, for example, there's been some really interesting cases that happened in Boston where they had patients who had been seizing in one part of the brain for sometimes weeks. And in the intensive care unit, couldn't stop them with medications. They went in and did that inhibitory, that slow, it went in and were able to shut off their seizures for temporary, then repeat it and stop it again. So there's really interesting things. We're not just exciting the brain. Some parts of the brain are overstimulated, and you want to go in there and shut them down. And so it's a fascinating new field. It's all part of this whole field called neuromodulation. So neuromodulation includes other types of stimulation, including deep brain stimulation. Some people have seen patients with Parkinson's have electrodes placed deep in the brain, and then they have a little pacemaker to turn on those stimulators. And so that's another part of it. There's all different ways to stimulate the brain that are now being looked at, and that are incredibly effective treatments. And because I'll just say one other thing, it's a fascinating thing. I get excited when I talk about this field, as you can tell. But it's in January of 2018, Pfizer, the big drug company, shut down their neuroscience division. They're no longer doing research on Parkinson's or Alzheimer's disease because no medications are working. Biogen actually had a study on Alzheimer's. They stopped the study, and then they just came back. They analyzed the data, and they said, well, maybe we got a response with this such and such. But medications, as we know, for a lot of these chronic neurodegenerative disorders, and they just don't work. I mean, even depression, we know that about 40% of patients don't respond to medications. So when we see all these, we see that medications can be incredibly effective for some people, but we're missing that 40% of patients or more sometimes. And so we have to have a different paradigm. We can't just say, okay, we give these drugs that increase this neurotransmitter. If you give, say, for Parkinson's, we give a